Good afternoon, everyone. My name is Raban Masuka. I am a postdoctoral fellow at the University of Cape Town at the H3D. We mostly deal with drug discovery and development, but I've, I should say, a very rich background in lots of areas. I've been in academic for the major part of my life, with about 6 degrees. I started off in chemistry, then I moved to law, and I then went to do a master's in intellectual property where I do patent drafting and patent designing, as well as patent litigation as well. If need be, I go to the court. But besides that, I spent most of the time in the lab doing drug discovery projects. So I went on to do a master's in chemistry, majoring in synthetic organic chemistry. Then I did cheminformatics in my PhD. And currently we work on different projects, particularly in malaria, in TB, and neglected tropical diseases. And I have particular interest as well in public health issues. So as something that I do when I'm free, I tend to focus more on health informatic issues. So it's more public health. So I'm also a lecturer at universities. I help. Currently, I'm on a sabbatical, a long one, so I teach students who are studying med lab science, students who are studying masters in public health, as well as students who are studying for their drug discovery courses. So it's a very long CV, which is not really. So we're going to try and have limited time. We're supposed to have talked at 11. But that is it may. We're going to try and look at how we can apply AI to particular about 4 fields that we use them. Most of the stuff has been talked about, so we're going to look at the current challenges that we have, as well as a few case studies, then we look at the current projects, time permitting. We've already talked about AI, and the key that we have in health sciences, particularly in healthcare, is data management. We also have issues to do with how we collect the data and how we store it, and how the data is normalized if anyone tries to do the normalization of data. It's also important to know how to trace the lineage of the data. So the first step is revolutionizing the existing healthcare systems. You know, in most cases we have these healthcare systems and none of the data is written in silico. So most of the data that you have is on paper. So how do we take the information from the papers into a system so that we build up a database? So there are lots of applications that we can have AI in healthcare. We can look at it from a record management system. We can look at it on how we can reduce the repetition of certain jobs. You know, this bottom-up approaches or top-down approaches, where basically you have 2 people, 3 people doing the same job in an institution. So we need to try and cut down on that and reduce the number of workers that we have in an organization. It is also important to do drug design, or actually treatment design. How do you choose the best service for your illness that you might be having? And how do you know when to take your relative or your friend who is not feeling too well? We're going to try and look at examples of how that can be done. We also try to look at digital consultation. How willing are you to use your app to try and treat your diabetes? How are you willing to use the app to treat your diabetes? How are you going to use it to find a cure for your malaria or for your tuberculosis, or for if you have biomedical imaging? How do you use that scan that you get from your radiology scan? How do you then take it up to find a solution to your problem? There is also use of virtual nurses. Lately we have had people who don't necessarily have to go to the clinic. You talk from the comfort of your home. You talk to a virtual nurse, and like using the app, then they will tell you the solution that you can have for your challenge. There's also medication management. How do you know when to take what and in what dosage? There are people who tend to forget they're supposed to take medication, right? So we try to develop systems where the system can remind you that it's time for you to take your medication and give you a reminder 15 minutes prior to that. There's a word that I need to clarify in science that we use. It's called clearance. So when you take a drug, the time that you take the drug to the time that the drug leaves your system is called clearance. Are we together? So assuming you have this virus in your body, and this virus has a lifespan of say 8 hours in your body, and you are taking a drug, the drug that you're supposed to take is supposed to last at least 9 hours to supersede the time that your virus spent in the body, right? So when you see a medication written, check 3 times a day, you're taking it, say you take it 8, you take it 1, you take it 5. What you're basically doing is that the time that I'm taking this drug, I'm anticipating that some of the drug is still in my system so that the virus does not mutate within you, right? So it is key that you manage the medication properly. There are people who forget to take medications, particularly if you're looking at diseases like TB. If you're supposed to take in the morning, afternoon, and evening, and there are lots of drugs that you take for TB particularly. And the other key issue is when you look at, it is important when you go to a doctor to tell the doctor that I am suffering from this problem and I probably traveled. You're supposed to tell the doctor that you have traveled. I'll give you an example of 2 neighboring countries, South Africa and Zimbabwe. The TB that we have in South Africa is called XDR, which is an extra drug resistant strain. And the TB that you have in Zimbabwe is called multi-drug resistant TB. So if you have traveled to Zimbabwe and you come with TB to South Africa, they will probably treat you as XDR instead of MDR. So the medication that you get is different. So you're supposed to declare where you have traveled. So it is important when we are developing the system, as you will see later on. It is also important for drug discovery. We talk about that, precision medicine, health monitoring, healthcare analytics. How do you gather information that you want as an institution? How do you know your catchment area? So you are investigate. Who are your patients, likely patients? Is there any transit route passing through here so that you know these people are going to pass through this area and these people actually reside in this area? That is, you do a design, or if you're an authority, you are trying to build more clinics around that area. How many are you going to put in, depending on the number of people who reside in that particular area? So the major challenges that we have is, for example, I said earlier, most of our data is manual data. How do you codify that data from text? The other thing, we talk of machine learning. How many experts do we have to get that information, and from mining from these vast data collections for diagnosis, for prognosis and therapy? Who knows how to take that data and use it sensibly? Earlier on I was talking to some people and we were discussing on this subject that I think you all know that doctors don't know how to write. Doctors don't write legibly, right? So how do you codify that information? What algorithm can you use to extract data from something that is more like a line so that it makes sense to someone? So this is one area that is a challenge that we have. The next thing is revisiting symbolic knowledge and model-based methods once the low-hanging fruit are picked. So when you have chosen the method that you're going to do that, how do you, is there any model that you're going to use that is knowledge-based? Someone talked about cultural practices. We have information like people who go to Sangomas, for instance. You go and get this kind of herb and you use the herb. That information that knowledge is not documented. So when you want to treat an ailment, or if someone has been successfully treating something, we don't know how to get that information. So we need to try and use indigenous knowledge systems as well and codify them so that we get data from that. So there are other people, if you visit some old folks, they will tell you, if you have a stomach bug, you take this and that and you use that. But that is not written anywhere. So for future generations, they wouldn't know that you take this bag to treat this thing or you take this food. So we want to find a way of modeling information so that we even take that data from that and have this collection of this traditional knowledge systems so that we use them for future references. So you talk of the estimations that I find in literature is about, we are expecting to have about 44 zettabytes of data by 2020, and we're currently sitting around 4.4 billion zettabytes of data. There's this transition from using data to analyze what happened in the past descriptive, and how can you use the data in the future, and how can it be used. So it is one thing to have the data, it is one thing to know how to use it, then it is another thing to use it to predict what's going to happen in the future. There are lots of assumptions that we use. We're hoping that all things being equal, right? So if things are not normal, what do you do? And if things are on the left or on the lower end, what about if they're on the upper end? What is the control that we have? How do we take this information and normalize it to use it? So when you look at this, one company has developed medical SIP, and this is qualified to assist in clinical decision making in radiology and cardiology. Yesterday we heard something about IBM Watson. They use it particularly, one case an example is one patient who was suffering from pancreatic cancer. So you take someone who's suffering from pancreatic cancer, you take the images that you get from the scans that you get, and when you get this information from the scans, you then, if you have a database that you have generated with all the treatment information, you scan through using the genomics of the patient to find the suitable image that you can then use as best medication for this cancer that you have. Does it make sense? So if you have this magical image that you got, you then go through the database, assuming you've collected all the data, and you're going to use machine learning and deep learning to try to extract. Someone was talking about the idea of pattern recognition, right? So you look at the pattern of the image, which are the dense areas, which are the light areas, which one is it similar to from the treatment that has been done previously. And you take that and you then say, this patient is best treated using this treatment method. You don't use that, you use this one. Or how are you going to help future generations? When you've collected this data, can you keep it for future use? A company in the Netherlands, I think I don't know how to read that, Zog Prisma Public, analyzes invoices and uses IBM Watson in the cloud to mine the data. They can tell if a doctor, clinic, or hospital makes mistakes repetitively in treating a certain type of condition in order to help them improve and avoid unnecessary hospitalizations of patients. I think it is also key that when you take patients to a hospital, you know that this is a good doctor, this is a bad doctor, right? The way you know that it's the data that you've collected, and you also refer to what people say about the doctor. Well, let me come closer home. People know that you are a better scientist than someone else, or you are a good employee, because we gather information, and to gather information, how do you use that? And as corporates, you take information from what people say about your employees, it becomes key in transforming your business. So currently, we are working on about 4 projects. The first one is one thing that is very close to me that I deal with, not necessarily with H3D, but I do it independently. The idea is to build a health management information system. The second idea is to do data-driven medication, where we say that when we look at the symptoms that you have, and when you look at conditions, and we gather data about your genomics and stuff, we can then design a customized medicine specifically for your ailment or for disease. The third thing is when you do drug discovery, then you also look at network pharmacology. We'll talk about this briefly. I got this interesting chart from Intel. They talk about artificial intelligence. Most of the stuff we talked about, it is good to talk at the end so you don't define lots of terms. A lot of people have talked about it. But the idea that is of interest is looking at machine learning when you look at the classical and the deep learning side. So when you look at the health management information system, maybe let me start by this idea. Imagine you walk into a clinic. What's the first thing that you're likely to do? You are given this board, you're supposed to fill in your information. So you fill your name, you fill in your date of birth, they check your blood pressure, they check your sugar levels, if any, they check your temperature, and they log you, they keep it on a piece of paper. Then next week you travel to KZN, and what do? They take similar information. If you travel to UK or whatever, they take similar information. They ask you for your name, they ask you for this other information. Do you need to be doing that regularly? You don't, it's tedious. So what do we need to do? In health management information system, what we're basically looking at is how we can manage the data that is already there when we visit the doctor once. How can we transform this data to use it at national level or at an international level? Is it possible that we can take all the medical records, build up a system, and put it in a cloud, so that when you find an identifier, maybe it's your national ID number, or maybe it's an independent identifier that you use. So use this identifier that when you plug in the identifier, we know that this is Joe who is coming in. when you put in the identifier that you have, we know that this person who is coming has traveled to South Africa, has traveled to this part of the country, has traveled to this area. So that if there are diseases that are related to an area that you visited to, we know that this is likely to be this ailment. If you're coming into South Africa, there is that requirement for a yellow fever vaccination, right? So for people who have traveled, you know, if this system is built, you relate it to the national registry where you look at your immigration papers. You link it to your bank's information, like for health insurance, so that when you visit a doctor and they look at your information, so they take in the biogeographical information that you have, they put it in the system, they now know your name, your date of birth, your blood pressure the last time you visited a doctor, it is already put in. They now know that you have come in and you have this blood pressure now, and you have traveled to this country. So if you have moved, if you say you're coming from Zimbabwe, if you have TB symptoms, they know that this is MDR. And if you have traveled from South Africa and you've gone to other parts of the countries. So if you're coming from South Africa, maybe let me talk about South African health system. If you walk in and you're coming from Mozambique, you're coming from Malawi, you're coming from Zambia, you're coming from Zimbabwe, and you have malaria-like symptoms, chances are you'll be treated for pneumonia in South Africa. Because South Africa has very few cases of malaria, right? So they mostly treat those as if the person is suffering from pneumonia. What are you getting is the wrong medication for the disease. And as a result, your liver or your heart starts rejecting the medication, and you develop other conditions that are not good for your health. So South Africans hardly treat malaria. They look at the symptoms, but the symptoms look like something else. But if you have this information and we know that you travel to this part of the country and the symptoms that you have, then we can tell that this is likely to be malaria. The other thing that we also need to look at is when you visit pharmacies, you get this piece of paper that you get from a doctor, a prescription. So with the health management information system, we take down all your information, and there are three key things that we talk about. So with issues related to accessibility. So it's not everyone who is going to view your medical records, because that's private data. I know you fight with people because of ethics. How are you releasing my information to everyone? So there is levels of accessibility and levels of security to the system. So the people who are supposed to only see your biographical data, the nurses and the reception, they only have access to your name, your address, where you're coming from, and your age. Then the medical doctors have access to your medical records. So it's not everyone who have your medical records. And then they will have access to, since this is linked to your medical insurance, you don't need to pay when you walk in, you don't need to write anything. The only thing that you can probably need to do is maybe to use your fingerprint so that you identify yourself as the actual person who has walked in, that no one can use your identifier. Then when you have this system, when you say you have gone to do your radiology, and you get your medical images. When the medical images come in, the doctor does not have to wait for the service to send the document to you. It is already put in your database. So the next doctor that you visit, so if assuming you live from Joburg, you want a quick flight to Cape Town, you go to the doctor in Cape Town, they have the record that you had in Joburg yesterday. Then they will treat you adequately and efficiently. So it is a system that we're trying to build and use. The next thing that you talk about is ethics. And when you look at that, how do you get information from these people that are around you? So it means there's lots of documentation that has to be done. So you have people who are going to capture this data and put it in a system and look at the different, so that when you categorize, when someone is doing a study, say you're doing public health, you need to look at the epidemiology, endemics that are in South Africa. You can then look at them. Are you looking at TB? Are you looking at malaria? Are you looking at the influenza virus that is spreading? Are you looking at HIV and AIDS? Are you looking at this? So you have all that information, and then you know the population. And these people who are doing research will not have information to rise to your name and your privacy. They only get the information about the number of people who are doing this. So it's an important system that can be integrated to support research, public health, and patient care as well. So the next thing that we also think of is to use the electronic health record so that when you have gathered enough information, the nurse practitioner will be able to take into account a patient's entire medical history by pulling up accessible, private protected and health records. So these people will look at this information and help you to give you the right treatment at the right time. Assume you have no one and you have fainted and you are going on a trip. Say you collapse and there's no one to tell the doctors that you are hypertensive. You walk into this place, they will just give you medication. But if we have such a system, when they look at your record, when they look at your identifier, they will quickly know that this person is suffering from hypertension. So the treatment that they will give you will be for someone who is hypertensive. When you look at the 3 diseases, let me give the example of these 3 diseases. Hypertension, diabetes, and arthritis. You know these 3 diseases. They all hit the same target, the medications. So it is likely that someone who is suffering from hypertension will develop diabetes with time. Then they will have arthritis. So if you say you are suffering from arthritis and you go to a doctor and they don't know your history that you are hypertensive, they might give you medication that might stimulate your diabetes. So you need to have the proper, I think you've read that don't use this medication without consulting your doctor. They are doing it so that you may ensure that you are the right candidate for the right medication that you are taking. Don't share your medication with someone else without consulting a doctor. I think we've seen people who share medications. You're in the office, you have this headache, like, just give me what you were given by your doctor last visit. You're not supposed to do that. It is not good. So we'll talk about that. Then let's quickly talk about data-driven medications. In 2015, we did a study with a couple of friends. What we did was we gathered genomic information about all patients who are suffering from HIV and AIDS. When we looked at when we did the genomics of these people, we sent the data through to Japan. And when the Japanese analyzed the data, they only gave us the analytical results that we got after asking them for this, because they had supercomputer and Zimbabwe had no supercomputer then. So what then happened was when we requested for the results that they got, because they got interesting results, the trend that we found from there was that the people with a Caucasian heritage respond better to ARVs than those who are not Caucasian. So when we did the trend analysis, we then discovered from that if you are to treat someone who is HIV positive and they are not Caucasian, it means the dosage that you give them is different from the dosage that you give a Caucasian. So when you do that, you have data-driven medication. When you look at the trend, or when you look at so you know every person is different. We have different genomics in our system. Our DNA is different. We respond to medications differently. So when we do data-driven medicines, we use deep learning, which can handle a broad spectrum of diseases in the entire body and imaging modality. So someone has talked about the application of deep learning in imaging. So we use that more like the same system, where we are then saying that this person we are seeing this trend. For example, if we look at someone who is suffering from, important organ in our body is the liver. Right? The other people think that it's the heart, but the important organ in our body is the liver. Why? Because the liver is responsible for metabolism. So every time that you take a drug or food, the food goes into the body, it is absorbed by the small intestines, then it gets into the bloodstream, and then it goes to the liver, where it's broken down into small pieces, where it's metabolized. The actual drug that ends up working in your body is called a metabolite. So for people who are suffering from, say, liver cancer, their ability to metabolize food is gone. So when we do say metabolomics, we are actually studying the trend, how the drug moves in the body until it's metabolized, so that we see what works at the end of the day. So what we intend to do is to then synthesize the metabolite, so that the person who is suffering from liver cancer will just have that drug. They don't need to metabolize it, it will go to the site of action. Then we can treat the disease. So if someone is suffering from liver cancer, the current medication that we have cannot be metabolized, so the person will excrete that medication and it won't be useful to you, but you've paid lots of money to find that. So we are hoping that when you use precision medicine, this deep learning has this capacity that you can analyze the meaning and context of structured and unstructured data in cleaning out nodes and reports that may be critical to selecting a treatment pathway. So we look at the trend, your family records, we have them, and we look at, so your mother had hypertension, your brother had hypertension, your sister had hypertension, or they had eczema. So chances are your siblings will have this disease. So when we look at you before you have the disease, I think you've heard of the Human Genome Project. When you look at the disease when you look at the trend, then you can tell this person is not yet suffering from hypertension. How can we help them before we suffer from that, since they are in their bloodline? So we try to use precision medicine to counter that. So we can talk of deep genomics, which aims at identifying patterns in rich data sets of genetic information and medical records, looking for mutations and linkages to disease. So when you look at diseases, usually if there's one mutation, the mutation is conversion of one amino acid in the polypeptide chain into another. So that mutation, the drug that we then use, for example, the closest disease that I know is malaria. So when you we have a strain called Plasmodium falciparum, right? That's the strain that causes malaria. And we have the drug-resistant one that we call AK19. So if someone was using chloroquine, and chloroquine now, some of the strains of Plasmodium has developed some resistance to that. The resistance is as a result of this mutation of one amino acid into the other. So what we do in our lab is that we synthesize or we develop these cells and we do the mutations in silico. So it's called site-directed mutagenesis. So we change the amino acids and assume the mutations that are going to come is this or that mutation. That as we design drugs, we are designing the drugs ahead of time so that if any resistance comes up, if any mutation is to occur, we already have a drug for that particular mutation. I think you remember the idea around Ebola that we had a few years ago when there was Ebola because of a mutation that happened to the previous Ebola target. So then by combining the attributes from the patient's file with clinical expertise, external research, data, and programs, we identify potential treatment plans for a patient. So the systems learns from existing data resources and hence data coming from this design, make, test cycle. So it is important that when we giving information to people, we say the right thing at the right time. When your doctor asks you for information, you need to state exactly how you are feeling. Particularly, the challenge that we have is called cross-resistance when it comes to medication. I think you have had situations where you go to a doctor, you get medication, but you don't feel well. One of the reasons is called cross-resistance. If you don't declare to your doctor that you are taking one particular medication and then you are given another, there are chances that your medication will cancel each other and you won't get the therapeutic effect. Particularly, it happens for ladies. If ladies are on the pill, chances are if they are suffering from, let's say, a stomach bug, they go to a doctor and they get say, you get an antibiotic. The antibiotic has a chance of cancelling the effect of the contraceptive. And as a result, in most cases, you get unwanted pregnancies because of cross-resistance. So it is important to declare every information because it becomes in handy. The third thing, that area that we talk about is drug discovery. In drug discovery, we generate lots of data. From 2014 up to 2015, I was working at the European Molecular Biology Lab in Kingston, Cambridge. And one of the things that we used to do was we developed a spreadsheet that would extract bioactivity data from databases. And then we use this bioactivity data that we generate to know that if we have this drug, we link it to that. The best example that we can give is local keys. That's drug discovery. For every disease, there is a target, and for every target, there is a drug, right? So imagine I give you a bunch of 100 keys and I ask you to go and open my car outside and I don't tell you which keys it is. So this is drug discovery. You have targets. Targets are proteins or nucleic acids, and you have a drug which is the key that you need to use to unlock the door. So in drug discovery, we have vast amounts of virtual compounds that we have. And we use machine learning approaches to identify which is the correct target for this drug on one hand, and we also use it to identify which is the correct drug for this target. So basically there are two approaches. We can use structure-based methods or ligand-based methods. In ligand-based methods, in most cases we do what we call QSAR, which is called Q-sub modeling, structure-active relationship, quantitative structure-active relationships. In that we mostly, and pharmacomodeling, we mostly depend on training sets and data and test sets. So you get a set of data, then you build up a model with your test set. So mostly we use the 80-20 rule when you do Bayesian modeling. So we use the 80-20 and we get a test set as 20% and our training set is 80%. So we train several models. And what we're basically doing, we use known targets and known drugs. So what we are looking at is so that the system, the model that we build, is supposed to be able to predict at least 92% accuracy that this drug hits this target. So when we have got the best model, then we can look at virtual compounds that we have that we don't know targets thereof, and we use them to run them through the system and to correctly predict the right target for our drug that we have. We also use the same thing to correctly predict the right drug for the right target for our drug as well. So, well, this was basic information. So you start with about, say, more than 100,000 compounds, and then the compounds, so drug discovery costs about $2 to $5 billion, in most cases $15 billion. And it usually takes 10 to 15 years. But with the advent of artificial intelligence, computational chemistry, we have reduced that time from that to about 5 to 6 years. And the investment also goes down. What it basically means is that you start with a vast database of compounds. Say, if you use the zinc database, there's 18 million compounds, and you need to choose one from 13 million. How do you do that? How can you choose one from the National Cancer Institute database? They have over 265,000 compounds. How do you choose the best one? So you start learning models, you use machine learning, you use deep learning to design or to identify one compound that will probably give you the best activity or best inhibition to your target. And when you get the one that you then get, then you go into the lab and you synthesize that, or you buy it. Then you do structured relationships where you change the functional groups to improve the drug and make it more useful. So I'm trying to rush through this so that we avoid wasting too much time. So we also design AI algorithms that we use. In most cases, in our machine learning approaches, we use Bayesian modeling, and we also have different softwares that have these algorithms that are already inbuilt. So we also use machine learning to predict how molecules will behave in a system. We also use it to identify targets for drug disease intervention. We also use to train neural networks to predict molecular structures of drugs. We also use it to correlate or label drug use and vis-a-vis the medical evidence to identify suitable molecules for drug repurposing. When we talk of drug repurposing, it's key. Drug repurposing is knowing that this drug works for this disease, right? Then we also take that drug and we try it on other diseases to see if it is not suitable for other diseases. We call it repurposing of a drug. The other word is called repositioning, where we change the drug. So, and the best example that we have is what we call the blue bullet, silver bullet. Many will know it. Inside we call it sildenafil. The actual name that is used by people is called Viagra. Viagra was meant as a drug for hypertension. That was its first use. But then one of the nurses identified that it can be used for something else. Then people took it and they repurposed it to use it for something else. One of the key things that you can do before you even try it, before you make anything, we start by, when we make our designs in the lab, we do tests, biological tests. We try something. If the drug is working, then we move into use it into mouse models. If it is working in mouse models, we look for healthy beings if we are sure of the results and we are safe. We look at the toxicity. And if it is safe, we look for healthy beings. we screen you, we check that you don't have any disease, then we infect you with our disease, then we start treating you. So it is possible that we can use you as our guinea pigs, then you try new drugs. So we can also use it for mode of action analysis. An example of mode of action analysis is this project that we did, where we were looking for a drug for TB. And in this we had about 6 million target ligand pairs that we had, and we managed to get 3 compounds from the database that we then knew that these 3 compounds hit a particular TB target. Then we took the three compounds that we had. Of the 3, we found out that 2 were more effective. And we took the 2 compounds, we evaluated the use that they have, used Bayesian modeling as well. And then we identified that these compounds are particularly interesting. Then we went to the lab and Del Brosara's lab in Birmingham. Then we used these compounds now to identify or to look at the TB genome. Where in the TB do they work and how can we use them? Then we optimized the compounds with the help of the guys at GSK. It was a collaboration. So the last thing that I'll talk about is the use of neural networks. When you look at a disease, say cancer is different from TB, it's different from nematode infections. Cancer is different from influenza, it's different from HIV and AIDS, it's different from any other disease. Cancer uses pathways, so it doesn't affect one particular site. So with cancer, it's more like you have, I think you've seen people with, like, say you have a blockage here of a blood clot or something. So when your system has a clot, the body will generate a new pathway so that your blood will flow on a different pathway. Then you start inflaming and stuff. So that's the same thing that happens to cancer. If you block one pathway, another one opens up. So with cancer, it's very difficult to design a drug for cancer without considering artificial intelligence. The best method that they use is artificial neural networks. That's the best way that you can do. So that when you have a drug that you have designed, you are supposed to split this design using your algorithm. To split a bit of it to block this pathway, another to block that, another to block that, so that you get a wholesome system that is all the pathways blocked. So using that, we designed with, I'm giving an example of work that has been done by Ben Allen at Therapeutics in England. So what happened with this, they did this using neural networks and the algorithm that they developed, and then they managed to get this compound. I'm sorry you don't understand our compound, but that's how a compound looks before you ingest it. So when they did that, then the drug was found to be very effective against some type of glycomas. And then what happened was that it was taken to phase 1 clinical trials and passed phase 1 clinical trials. Phase 1 clinical trials, you inject your disease in your mouse, and then you try the mouse. From the mouse, you move into dogs. From dogs, you move into humans. So currently, this drug has passed phase 1 clinical trials and is moving on into phase 1B clinical trials. And it is because of the use of artificial intelligence that we can see the transformation that we have in healthcare. It is also helping to shift the major shift in drug discovery. Previously, people used just synthesized compounds and throw them and try it using phenotypic screening. Now you make the right compounds, the top 3 that we have, and you use them. It is also improving accessibility to doctors and to nurses. You don't necessarily have to go to the clinic. You stay at home and you call your doctor and you tell them the symptoms using the app that you have, and you get a result. It is also helping to surpass all the conventional approaches that we have. I thank you.
Thank you. Any questions? Any questions for Raban? Yeah.
You talked about semantic data lakes that was created for the purpose of drug discovery. Maybe you can give more details.
Well, basically, we're looking at, for example, the work that we are doing in Kingston. What we basically did was we developed a spreadsheet, an algorithm that extracts data from about 46 journals. So we are taking that data and putting it in a database. Then what we are basically doing is we use that and from other sources and various steps around and creating a library that will, for anyone who's doing a drug discovery project, you can buy in or fit in into that stream and look at. The idea is to avoid reinventing the wheel. We want to see if this was tried for TB, and in my research I identified that yes, if it's an active hit for TB, I find out from that it was tried but then it didn't give a good therapeutic response. So it can be a false negative or it can be a false positive. So we try to use those data lakes that we have, that of this data that has been generated, to try to identify and help labs to avoid reinventing the wheel and wasting money synthesizing something that doesn't work. Thank you.
Any more questions? Okay. Unfortunately, I have to run. I've got a flight to catch, but I wanted to say thank you very much, Raban. It was super interesting. I'm actually very interested in healthcare and applications as well, but so I'll definitely follow up with you afterwards as well.